Hello, good morning or afternoon, depending on what time you're watching this. So today I'll be going through behaviour change. I'll discuss behaviour change generally as a concept. I'm sure not a lot will be new for people. And then I'll go through a couple of behaviour change theories and sort of how they're operationalised more in a research context, but also hopefully you can see how they're useful really in our clinical work. So when we look to implement a new intervention in an individual or a group or organisation, human behaviour is a critical component that we need to consider. So in our clinical work as pharmacists, we know that interventions across settings are not as simple as providing education or writing a guideline or developing a procedure. We can't facilitate smoking cessation simply by providing a list of risks to an individual, and we can't change prescribing habits simply by referencing evidence or printing out a guideline for a prescriber. Now, despite this difficulty in doing this, I hope we can all appreciate how important it is to change behaviour. So it's not recent knowledge. Hippocrates, who's often referred to as the father of medicine, said that health is defined on the basis of a balance between environmental forces and individual habits, which is honestly a very holistic view that I think a lot of, still these days, a lot of clinicians may not necessarily appreciate. So human behaviour and healthcare systems are complex and they're multifaceted and they're not linear. So when we're looking at designing or implementing an intervention, we need to acknowledge the complexity of individuals and their contexts for success. So the World Health Organization has stated that our behaviour and social circumstances may account for up to 60% of health determinants. So behaviour changes, models, theories and frameworks are used to help clinicians to understand the how and the why of whether an intervention works. They can be useful in a number of stages, so the planning phase, the implementation, and the evaluation stages, in order to identify, account for, and overcome the barriers and enablers to success. There's a range of behaviour change theories, and they've all got applications and different applications depending on what you're trying to do. So here's a few of the theories. So perhaps the most well-known is the stages of change theory, which is quite common in healthcare practice. And they've all got different uses and evidence bases. So there's the theory of planned behaviour, which includes three main areas of belief on an individual that the theory holds will dictate behaviour. So behavioural beliefs are the attitudes towards the behaviour itself. Normative beliefs are beliefs about the sort of subjective and the social norms. And control beliefs are the self-perceived level of control over a behaviour. And this will all lead to an intention to undertake the behaviour, which can then support the actual behaviour itself. The behaviour change method, the health belief model is a model focused on an individual's, unsurprisingly, health-related beliefs. So do they perceive themselves as susceptible? Are consequences severe enough to warrant attention? What are the benefits to changing their behaviour? What are the barriers to actioning the behaviour? Are they exposed to prompts to undertake the behaviour? And do they feel in control, or do they feel a sense of self-efficacy? As I said, the stages of change theory is probably the most common, where an individual goes through a range of stages of readiness to change. Self-determination theory is more of a motivational theory. So it's an individual would be optimally motivated when they feel competent or undertake a behaviour, when they feel connected and supported by others around them, and whether they have autonomy or control over their actions. Social cognitive theory involves the interplay between three different factors: their environment, their self or individual factors, and the behaviour itself. And each of these three factors, you can kind of think of it as an interconnected triangle, 3 points on the triangle. They interact with each other to either positively or negatively impact it. And they ultimately, all three, work to drive a sense of self-efficacy or a feeling of control of an individual over their behaviour. So when thinking about behaviours generally, and particularly around research and implementing interventions in healthcare, we can I like to consider three key stages. So we first need to understand the behaviour, and then we can design behavioural interventions to change this behaviour, and then we can implement and evaluate these interventions. And understanding behaviour change theories or models across these stages can be useful. They can be done separately or in combination. And a common framework that is often used in healthcare that I'll focus on is particularly useful to consider across all these stages. And that's the behaviour change wheel, which at its core has the behaviour change model, which is known as the COM-B model. So it's closely tied to implementation science, and it was designed to improve the evidence-based practice in healthcare at a policy level. So when we're designing an intervention, we start at the centre, and that's where the COM-B model lies, to understand the behaviour through that COM-B framework. And then we move out to the red or brown areas where we've got explicit interventions that are related to these behaviours. And then we move out again into the grey, which contains the policy level categories which can guide these specific interventions from a policy level or organisational level. So the COM-B model describes three categories that influence human behaviour. There are capabilities, which is what you can do, opportunities, down the bottom there, which is whether or not you're exposed to the circumstances and potential to undertake specific actions. And then both of these impact the motivation. So to go a little bit more into depth, so capability is described as an individual's physical or psychological capacity to engage in the activity. So for example, we might consider deprescribing benzodiazepines in an aged care home, where we want to implement a multidisciplinary exercise physio and pharmacist education intervention. The physical capacity primarily revolves around physical skills. So do the residents that we're intervening on have the physical ability to participate in exercise? Are their exercises appropriate for their physical capability levels? Psychological capability is related to their internal abilities, such as their knowledge or their memory. So do the residents have the ability to remember to do the exercise and to follow the guidance? Will they be able to follow it without constant reinforcement? Will they remember the information if the pharmacist is providing them a list of the risks on benzodiazepine, long-term benzodiazepine use? Capabilities are also divided into two components. So there's social or the cultural influences, one opportunity. So back to our deprescribing example, is everyone in the facility involved in the program to support each other, and everyone who's doing the exercise in the facility, are they doing it at the same time and receiving the education as a group? Or is only one person involved, and thus would participation potentially get in the way of them participating in other social activities within the facility? For physical opportunities, are they provided a location to do the exercise? Or do they need to search for a suitable location in the facility or go outside? Have they been provided with physical resources to guide the exercise and physical reminders of the risks of benzodiazepine use? And finally, we have motivations. So they can be automatic or reflective. So automatic motivations are the intrinsic responses. So is someone potentially fearful of benzodiazepine withdrawal, and will that affect their involvement in this program? Do they have an old injury where they're often guarding and avoiding certain movements that will affect their participation in the exercise? And thus that will reduce their ability to exercise earlier in the day and sleep better at night. And then reflective. Do they have a goal to become more self-sufficient and not rely on medication for sleep? Do they understand the consequences of long-term benzodiazepine use? And does this understanding reinforce their motivation? Or have they been told, the biggest risk is a fall's risk? They've never had a fall, and therefore it's not relevant to them, and it's not meaningful, and then therefore it's not working on their reflective motivation. So this is a larger image of the behavior change wheel. So the capabilities, opportunities, motivations, and the COMBI model in the center in the green. Next, we move out into the red and brown. So we look at the actual interventions that can impact the behavior. So we've identified early on that maybe psychological capability is really something to target, because individuals just don't know about the consequences of long-term benzodiazepine use. They've never been educated. So we might have also identified that individuals can't participate in the exercise that's supposed to sort of provide them with a better sleep at night, because they haven't. When they're given an exercise plan from the exercise physiologist, they don't know how to do the movements. So they're told to do a squat, but they can't. They don't know how to do it. So out here, we might then select education as the primary intervention. And that might look like the development of a guideline for staff that every time a benzodiazepine is commenced or a resident is admitted on a benzodiazepine, they're enrolled into a program of monthly education sessions. Staff receive education so that they can support it and then reinforce it. And that comes into that guideline in the grey on the outside there. Or down below, we might identify that automatic motivation is the problem. People can't participate in exercise because they've spent years becoming used to not moving. And when we say exercise to them, they automatically imagine going to the gym and doing heavy squats, and that doesn't suit them. So what we might do is we might use enablement, which you can see there sort of in the brown, where we might run guided exercise sessions focused on safe progressions and guided by the exercise physiologists, where they just walk slowly at first, then a little bit faster, and they're exposed to progressive introductions in a safe and structured way. At a policy level, this might look like service provision down there in the grey, which will involve maybe a corporate level development of a plan for financially organising this, or logistically organising contacting and accessing and involving that physio or exercise physiologist in that program, and organising timetables and schedules. Now, this is an image that it was in the original paper on the behaviour change wheel, but it's been slightly modified by choosing wisely from the Australian government. So it shows on the left-hand side the aspects of the COMBI model, so the main three and then the two subcategories of each. And it shows the intervention functions that can support it. So for opportunity in the middle, both physical and social, they're best addressed by interventions that focus on restriction, environmental restructuring, and enablement. So it provides us with a practical guide to develop the interventions, and then from there to develop policies that are all based on the aspects of the behaviour that we've identified as barriers or enablers to that behaviour. Now, the behaviour change wheel goes even further than this. It's quite rigorous, and it provides further detail for each intervention, how it might be enacted. So, for example, here, training on the right-hand side as an intervention can be used across all aspects of the COMBI. So it's useful for the capabilities, the opportunities, and the motivations. The intervention functions in the middle, so the training in there can be useful for that. And then with training, we can operationalize that by demonstrating the behavior, by instructing, by providing feedback on the behavior itself, or informing of the consequences. So that very right-hand side is known as the behavior change technique taxonomy, or the specific functions within the intervention that can be used to address that particular intervention that will address specific behaviors that we've identified. So we can use all of this obviously practically if we know what the behaviors are that we want to change and we have the resources and all that sort of stuff. But we can also probably see some opportunities for research. So when I say research, I don't just mean formal academic stuffy research. Research is as simple as a quality improvement activity in your workplace. If you do a drug audit and feedback, you've done research. So we can start at the beginning and understand the behaviour. So can we conduct an audit to identify what behaviours might be problematic, such as overprescribing of topical steroid durations in an aged care home. Can we then undertake interviews and surveys and focus groups to find out what aspects of these behaviours are a problem? So, do people have the knowledge of how to treat eczema non-pharmacologically, or are we having to rely on steroids because everyone is, using heavily fragranced body washes and no moisturizers? From here, we can then begin to design behaviour intervention. So working with the staff to develop something that fits their needs, maybe undertaking a co-design project, or we can conduct a literature search to find out how others might have solved a similar problem. And then we can implement and evaluate an intervention. So can we provide education sessions once a week for staff, residents, and families about appropriate use of steroids and non-pharmacological options to see if that has an option? Can we make sure that everyone has access to a fragrance-free moisturizer and facilitate that throughout the entire facility? So this has been done in research. So this paper, they wanted to use the behaviour change wheel at the first stage, so to understand and address the barriers to naloxone supply in Australia. So naloxone at the time of this was widely available, but had very little uptake from community pharmacies. So they used this model to investigate the causes of the behaviour. So right up to the beginning of that chain that I described earlier, they explored the barriers to the supply of the naloxone, and they developed their questionnaire based on the COMBINE model. So, for example, do pharmacists know what naloxone is? Are they able to engage people who seem to have, who are at risk of overdose? Do they actually physically have the naloxone? Is it available to them? Can they order it from their suppliers? Do they have resources to provide advice to individuals who might be at risk and to complement the naloxone supply? And what are their beliefs? Do these pharmacists actually, do they think that people need naloxone? Do they think it's good and necessary? Are there incentives or disincentives to supply it? And then from here, they identified certain barriers, such as poor knowledge and confidence, and they mapped this to other aspects of the behaviour change wheel. So education and training and enablement should improve this knowledge. And then they recommended policies, so on that grey area of the behaviour change wheel on the outer level. And then they went so far as to create examples of specific behaviour change techniques to implement, so that the BCT taxonomy in that previous table. So they were able to develop policy recommendations from their qualitative work that they undertook with pharmacists, which I think is pretty cool. Another example of using the behaviour change model in qualitative work is this paper here. So these researchers, they explored the perceptions of pharmacists regarding inappropriately prescribed analgesia. So they conducted semi-structured interviews, which was similarly informed as the previous study, informed by the behaviour change wheel, and they deductively coded the transcripts using the COMBINE model to identify the themes and the sub-themes to map directly to the COMBINE model. So they've undertaken their interviews, they've recorded them, they've transcribed them. Have a look at the qualitative analysis video if you haven't already. And then they deductively mapped those transcripts to the COMBINE model. So they came in and analysed those transcripts with that model in their minds. They may have had it physically written out, and they've coded the transcripts and tied themes to specific parts of the COMBINE model. And there's a graphic from the publication results where inappropriately prescribed analgesia is defined as the behaviour. And for each of the aspects of the COMBINE model, they've identified sub-themes from the data that could be used to influence that behaviour. For example, social opportunity could be supported by facilitating a GP and community pharmacist relationship, and physical opportunities that included access to medical records, regular visits to the community pharmacy, and other things. So they've on the far right-hand side, that's what they identified throughout their qualitative research, and they've applied that to the COMBI model for a rigorous framework in order to present their data and to provide something that's practically useful for people to follow. Again, so the authors went a step further again, and the sub-themes that were deductively identified were then mapped to an implementation science framework, which is the theoretical domains framework. The behavior change wheel was actually developed sort of with the theoretical domains framework, or the TDF, in mind. And then they've selected specific behavior change techniques in order to facilitate it. So for motivation, for reflective motivation that I've highlighted there, they've identified a sub-theme where pharmacists didn't have the confidence to make a decision. And that reflects on certain aspects of the theoretical domains framework related to intrinsic beliefs about capabilities. And then the specific behavior change technique in the BCW to address this was verbal persuasion about capability. So this might look like, demonstrating to pharmacists their historical cases of success, reinforcing these successes in the past in other areas perhaps, or in some other way empowering the pharmacists to be confident in their own abilities. So they used that to inform all the aspects that they found was contributing to that low supply. So to very quickly summarize, there's a range of behavior change theories and models, and we can use these for a range of purposes. We can simply use them to explore and address suboptimal behaviors. We can design and evaluate interventions and research, or we can use it to implement findings. And we can use it to do all three of these. So I hope it's clear from all of this, but at its core, single interventions with a single focus are not enough to change behavior, particularly in the complex world of healthcare. There's often a tendency in healthcare to try and resolve any issues with education, but this doesn't explore the actual root causes for behavior, and it's simply not adequate to explain and guide complex social and psychological processes. So I hope this provides a little bit of background on behavior change theories and the idea behind it, and the COMBI model. Thank you very much for bearing with me through this. And please ask me any questions. Thank you.